Hey everyone, let me know if you can hear and see me. It should be working. Hello, hello. Thank you all for joining me. It was great seeing you guys in lab yesterday. It feels like seeing you all in months. Awesome, you guys did awesome yesterday with all the case presentations and whatnot. Only killed the patient once or twice, accidentally giving him penicillin, so that's good. Improvement. I'm just kidding. Tell anyone. Be a bit distracted today. One of my close cousins is his wife went into labor today, so I'm looking for text messages to see if a little bun comes out of the oven. It's pretty cool. It's a little early, about a week or two early, but that's all right. Those babies come when they want to, as it turns out. I don't think I'll have to stop streaming. I'll just maybe say, "Oh look, it's born," and then that'll be it. I feel like the first ones always like take forever. I think my first one was like 16 hours of labor, and then the second one was like 2 or 3. It was very quick. I mean, it was really challenging for me to be standing there being supported for 16 hours straight. It was just it was something else. I'm just kidding. No, yeah, it was awful for her. She had good epidural support though, so that was more important than anything else. Anything I could do. Hello there. I'm gonna start about a minute here, and if you have questions, post them up in the chat or on the sticky board. So that's 12:30. All right. Okay, so I started recording. Oh man, only 23 people. Boy, my viewership has dropped off since the test, which is to be expected. So that's okay. They always come back and watch the Kyle. All right. So I don't see any questions up so far. So I'm just going ahead and go ahead and hit the ground running. So anyway, so we were talking about got through all of our rheumatoid arthritis and osteoarthritis and all of that. Let's continue talking about the bones. So we'll talk about osteoporosis and osteomalacia and how we are going to manage that. You guys have probably already talked about this. Basically, with osteoporosis, we're seeing sort of a dysregulation between laying down new bone and resorbing bone and calcium primarily from the bone there. And the reason why we care so much is because as the bones get more brittle and frail, they tend to have a tendency to fracture, which is not great. There's been plenty of cases where patients, when they have vertebral fractures, femur fractures, etc., quality of life, their ability to carry out activities of daily living are severely impaired, and they do see pretty significant increases in mortality associated with these fractures. So, ideally, we're going to try to prevent those as best we can, and one way to do so is with our pharmacologic agents here. However, I do like to point out things that have a tendency to be associated with osteoporosis. I highlighted just a few here just as an examples of things we either have talked about or we'll get into a little bit later on. You can see that there are plenty of drugs that are associated with osteoporosis, and it's important to try to identify those on your patient's profiles, so that way if it's something they don't need to be on, we'll get them off of it. And if they do need it, then maybe try to find some ways to sort of mitigate the actions of those drugs. A couple examples here include things like aromatase inhibitors, which we will talk about in the OB-GYN section coming up later on. Those are going to be important in terms of changing the levels of estrogen in the blood. We know, of course, our corticosteroids and glucocorticoids have major effects on the bone over the long period. So kind of goes hand in hand with the rheumatoid arthritis patients we were talking about, and how them being on corticosteroids for so long can certainly predispose them to things like osteoporosis. And even proton pump inhibitor, just like we kind of talked about in the last exam, how you can affect the solubility of calcium and how well it's able to be absorbed. And so chronically suppressing acid secretion in the stomach can actually lead to less calcium being absorbed, and thus you got to pull it from somewhere, and most often it comes from the bone, and that can be leading to the osteoporosis. One of these things in and of themselves probably aren't enough to cause it all on its own, maybe high dose glucocorticoids, but it's that all the other things going on with the patient, vitamin D deficiencies, calcium deficiencies, menopause, all these different things that sort of all kind of culminate with one another to cause these bones to become more brittle, right? But basically, the balance here is going to be between bone resorption, which happens with the osteoclast. They break down the bone. Bone formation happens with the osteoblast. I always think about Fraggle Rock when I think about osteoblast and class, with the dozers trying to build up their little castles, and then the Fraggles coming in and taking them down. It's a little outside my age bracket, but certainly outside most of yours, I imagine. But anyway, we know that this can be affected by a huge number of hormones. Predominantly, though, we're going to see that a lot of our sex hormones, things like estrogen and testosterone, are going to be big ones here. These tend to have positive effects on the bone in terms of laying down new bone. PTH, or parathyroid hormone, is going to have the opposite effect typically. PTH is going to have some other actions as well, but the main thing here is just trying to regulate calcium levels as sensed by the parathyroid, and trying to adjust it as needed, which we'll talk more about in just a few moments here. But we'll find with osteoporosis, you're favoring resorption, which is what's making those weak and or brittle bones. So calcium homeostasis is mainly maintained by vitamin D and PTH. We'll find that both of these have effects on a couple of things. One, on the absorption of calcium from the GI tract, and also on the renal reabsorption, right? Your glomerulus will filter calcium at the glomerulus, but we have transporters that can suck it back up into the bloodstream, and vitamin D and PTH have positive actions both to increase absorption of calcium and to reabsorb it from the kidneys. Note though, when you think of vitamin D, you think about going outside in the sun, and you spend the day at the beach. I'm good on vitamin D. But that's not really the whole story. You might have heard this in other classes, but the typical vitamin D you get from your diet and also from the skin is not the activated form. So like from your diet, you might be getting ergo or cholecalciferol, vitamins D2 and D3. I always get the two confused, which one's which. But basically, that's the inactive form. It has to go through an two-step activation phase, which I'll talk about in a little bit. But at the end, what you're going to get is this 125 dihydroxy vitamin D, or this is calcitriol, is another name for that. When we get into vitamin D supplements, this will be an important name to remember. That's the active form, and that's what's going to stimulate calcium absorption and retention from the GI tract and kidneys, respectively. And we'll see that when the parathyroids detect low calcium levels, they'll be stimulated to release PTH. And that will also help out with calcium reabsorption in the kidney, but it also will stimulate osteoclast activity when an elevated level chronically, to cause more bone resorption. The big thing here, and again, you always think about women, older women being particularly at risk for osteoporosis, but certainly men can too. But a big player here is going to be estrogen deficiencies, which is why this is a concern when you have patients who are approaching menopause. Once they hit that point where they start to produce less estrogen, you're going to see there's going to be favoring osteoclast activity. But certainly this can happen sooner if you have patients who have estrogen deficiencies due to cancer treatment for breast cancer. Various things can do that, which we can talk more about as we get into those endocrine section. We'll talk about that in OB-GYN as well. So anyway, in terms of our treatment goals here, we would like to make sure that we can try to prevent low bone density as best we can, which we'll talk about some means to do that. But then once we already have low bone mass, we would like to try to stabilize things. try to build up that bone, back to where it should be, and then try to prevent fractures. That's really like the number one name of the game here. Prevent the fractures, because we know that has such a huge impact on the patient in the long term. And then once the fractures occur, obviously we'd like to be able to, manage the pain and deformity, try to make sure their quality of life kind of gets back to where it should be, and then hopefully prevent future falls and fractures, right? And again, you can imagine how, especially patients on many medications, fall risk can increase because of just, dizziness and orthostatic hypotension. On top of being osteoporotic, this is something you see more often than you might expect. Let's get into non-pharmacologic therapy, starting out with some of our supplements that we can get, things like calcium. Usually you'll see this as calcium carbonate, the antacid we've talked about in GI. Although from a patient compliance standpoint, this is not great due to the side effects. So constipation, hypercalcemia probably shouldn't be a big risk if we're trying to supplement it here. But things like kidney stones and nephrolithiasis can happen here. It also becomes kind of a challenge due to the drug binding other things in the GI tract. So if you had someone who had hypothyroidism on top of osteoporosis and you give them calcium along with their thyroid supplement, well, they bind up each other, and they prevents either from really being able to get absorbed and do its thing, right? Antibiotics, etc. We'll talk about the bisphosphonates here in a moment. That's going to be our main drug class we'll talk about for treatment of osteoporosis. But vitamin D is the other big thing too we're going to be talking about here. A lot of patients are going to require exogenous supplementation. Most people are not going to be either getting enough in their diet, or they're not getting enough outdoor exposure for them to really get adequate production or consumption of vitamin D. So that's why we can give exogenous supplementation. This is the point I wanted to make here, is that patients with hepatic or renal impairment, they may not be able to activate the vitamin D on their own. And this is something we'll get into a lot in the renal section later on in the semester. But basically, ergo or cholecalciferol, which is the main forms we're going to be getting from our diet, that will go that two-step process where basically it puts on 2 hydroxyl groups, one in the liver to form calcifediol, and then the second hydroxyl group is added on in to make 125 dihydroxyvitamin D, which is calcitriol in the kidney there. So if you have someone with poor kidney function, they may not be able to form that activated vitamin D. I can give them all the ergo calciferol I want in the world. It's not really going to do them a whole lot of good because they cannot activate it. So that's why we can supplement in those patients and give them calcitriol, basically kind of cutting out these middle metabolites here. So we're going to find that medication is pretty frequently needed to treat and or prevent osteoporosis, especially in patients who are getting older. We know the risk is going to be going up there. And then as their density gets lower and lower, the risk for fracture goes up pretty significantly. And this is what we're trying to look at, is over the course of say a 10-year period, what is the risk for fracture based on their bone mineral density, and trying to treat based off of that, basically. So let's talk about our antiresorptive therapies we have. We already talked about calcium and vitamin D. We'll get into our bisphosphonates, which are going to be sort of our go-to drugs here. We'll talk about our estrogen agonists/antagonists, which are called SERMs. We mentioned these briefly in the oncology section back when we were talking about things that could help to treat breast cancer, for instance. We'll talk about calcitonin, denosumab, estrogen, testosterone, and a few other miscellaneous agents here. So let's talk about our bisphosphonates first. These are pretty easy to identify for the most part because they end with dronate. So like alendronate, ibandronate, and resendronate. And then those are all oral agents. And then there's an IV form called zoledronic acid. So of course it had to be a little bit different there. This one, we'll talk about sort of the differences and how they're used in just a little bit. But how they work is basically they're mimicking this product called pyrophosphate. And this is actually a natural product that we form ourselves that helps to inhibit bone resorption. They basically will inhibit the osteoclasts from working, basically. And so we're giving a synthetic form of that to basically get the same action there. So you see fewer osteoclasts that are maturing. You're getting fewer number, bone adhesion, lifespan, etc. Looking at the kinetics here, it's pretty poor actually when you look at it. So for the bisphosphonates, they have less than 1% bioavailability. So you're like, sounds pretty miserable. Why are we giving these things orally if that's the case there? Well, we dose them such that even that less than 1% is going to be okay. However, you're going to find that this is going to be a big one to consider how we are administering these things with like drink and food and things like that. So it's really strict in how patients need to be getting these drugs here. Okay. Once they get absorbed, it's actually kind of interesting. They have a little bit gets eliminated renally, but a lot of it gets incorporated into the bone itself, and actually has a half-life of up to 10 years because once it gets stuck in the bone, it's kind of there for like a really long time, so it's just kind of neat. But we're going to see that, as I mentioned, orally, these need to be taken correctly, which I'll tell you what that is in just a moment here, in order for any absorption to occur. Okay. In terms of adverse drug reactions, these frequently cause a lot of GI upset or like gastroesophageal sort of irritation. You'll find these tend to get stuck in the throat frequently, which can cause a lot of irritation. There's been cases of even esophageal erosions and ulcers forming from people not taking them correctly. And then a kind of unique side effect here is also called osteonecrosis of the jaw, which is, you can just look up pictures of that and it gets pretty gnarly there. So that's something you definitely want to monitor for. And this is probably due to sort of disrupting that normal process of osteoclast and osteoblast activity, right? There's normally a balance there, but this is what we're trying to restore. And unfortunately, this is a side effect you can see there. So looking at this, how would you want to take a bisphosphonate? Well, basically, you would take the oral tablets. Basically, the first thing, it's easiest that they take it first thing when they get up because they're in a fasting state and they don't have anything else on their stomach, presumably. And so basically what they're going to do is they will take the oral tablets, normally with like 6 ounces of water, no coffee, tea, orange juice, nothing else, just plain water here, right? And basically we need them to stay upright for at least 30 minutes. And they should be doing this about 30 minutes before consuming any of their foods or liquids. And you're like, boy, this sounds like a hassle. It certainly is. Some of these older patients, they can't stay upright for 30 minutes, and that can be a challenge too. So if they can't really comply with this, or maybe they're taking it, but you realize they're not really taking it that well based off of history or based off of their scans, this is where we can get into using something like zoledronic acid. Okay. So a lot of these drugs, because they have a long half-life, may be given weekly, monthly. But what's interesting is that if you had someone who either, they didn't want to take it all that often, they don't want one more chronic med to think about, or they can't absorb it well because of, not being able to sit upright, whatever the case may be, they can utilize zoledronic acid as an IV infusion and just get that once a year. So that's kind of one big draw of zoledronic acid. You only have to do it once a year, and then you're kind of done. So some people prefer that. A few different options we have there. Let's say that our bisphosphonates are not going to be sufficient, or maybe our patients cannot tolerate a bisphosphonate. We have a few different options here. First off being denosumab, which you can tell right from the name that's a monoclonal antibody. Basically, it binds to this rankle protein. Normally, rankle will bind to rank receptors on the surface and basically stimulate osteoclast precursor cells to mature. So if I basically bind up that rankle protein to prevent it from activating the receptor, you have fewer osteoclasts being made there. So that's how it's going to work to basically change that balance, so we have more osteoblasts working and fewer osteoclasts there. Because it's because it's a monoclonal antibody, it's injectable and is dosed every 6 months. So again, from a compliance standpoint, fairly easy to do as long as they keep up with it and put something on their calendar to get their next dose. Again, you can see some dermatologic reactions from injection site issues, skin infections have occurred, and then there could be some theoretical concern from, again, in disrupting the bone turnover from normally happening, because it's normal for osteoclasts and blasts to be working at the same time to get good turnover of the bone itself. However, by disrupting this as heavily as denosumab does, there's some concern that you could have some issues here. Kaylu's asking, would the same recommendations be made for vitamin D supplements? Sorry if I'm jumping the gun. In terms of like dosing, or in terms of what are you thinking specifically? I know what you're thinking. Someone says, oh, okay, some questions here. Someone says, does osteonecrosis of the jaw specifically have to do with the fact that administration's PO? Actually does not. It only has to do with the drugs in general. It happens to be the jaw tends to be more susceptible to this for whatever reason. And so in this case here, PO IV does not matter. It's just any of the bisphosphonates can do that. Good question. May have missed it, but could you explain why they have to sit upright after taking the meds? Yeah. So for the bisphosphonates, they need to sit upright such that gravity can assist getting that tablet down through the esophagus and into the stomach. And so in this case here, if they are like laying recumbent or for whatever reason, it has a tendency to adhere to the side of the esophagus and can sit there and cause erosions, ulcers in some cases, perforation rarely, but irritation at the very least. So they're going to get those kind of GERD-like symptoms as they are using that. So that's a common drug-induced cause for GERD symptoms is a bisphosphonate, basically. You can go back and look at our GI slides for that. Would zoledronic acid cause the same GI upset issues since they're only given once a year? Would that be a year-long side effect? No. So the GI effects from the bisphosphonates, those are strictly with the oral formulations because, again, they're in direct contact. And again, it's more the esophagus than the stomach. If it gets to the stomach, it's usually fine at that point. It's really just that irritation of the esophagus. So that is going to be oral only. The IV form would be able to get around that. And so you would not expect that to be a year-long thing with the zoledronic acid. That'd be a pretty crummy drug to give if you were just feeling GERD symptoms all year long. So we would not like that. I see Nicole saying, are there any problems with missing a dose or taking too early? In terms of that, not in particular. I wouldn't say, if it was something like zoledronic acid, if you took it like a month early, probably not, I wouldn't expect. In terms of missing doses, certainly if you miss it, then it's not really going to be working all that well. So consistency is important, but it's not like, there's going to be a night and day sort of difference there if they miss one dose. Probably not. Some drugs you definitely don't want to miss any doses of, like birth control, but we'll talk about that as we get in. Questions. So Kaylee was saying in terms of how you take it, like bisphosphonates. No, so vitamin D can be taken kind of however, but I would definitely separate it 30 minutes after the bisphosphonate. So if a patient has like a pretty complicated med regimen, bisphosphonates always be first. However, that may be only like once a week they're taking it, once a month, depending on the form that they're taking, which I didn't want to get into too much detail there. Oh, no, so the vitamin D you can take with anything, basically. You shouldn't have any issues with that. Yeah, because, I mean, vitamin D comes in your food, Maybe if you're munching on some mushrooms or something, a lot of vitamin D there, I know. Yeah, no issues with that as far as I know. Or maybe Shelby can shed some more light on that if she has any thoughts. I always love having a dietitian or nutritionist in the class. It always really helps me out. They can provide some extra insight for stuff I am woefully ignorant on. But anyway, so other things we could do here too. So, again, if a patient, the reason why they're osteoporotic is because they're lacking estrogen. Well, perhaps there's some things that we could do for that in order to help mitigate that. And so this is where raloxifene comes into play here. I'm not going to talk about it too much here. Obviously, this slide set normally comes after OB-GYN, but when I just left it because OB-GYN's in this section anyway. So we're going to be talking about that later. But basically, by utilizing drugs that act as an agonist of estrogen receptors in some tissues, that's going to be beneficial for that. So for instance, with like raloxifene, it's going to be acting as an antagonist in the breast tissue, good from a breast cancer standpoint, but it acts as an agonist in the bone. So you kind of mitigate the actions of estrogen in the breast, but you get positive effects on the bone. That's a great thing because then now you're having less risk for osteoporosis. The big challenge you're going to see with a lot of the meds you use for things like breast cancer that limit estrogen activity is you're going to see a lot of osteoporosis associated with that. Yeah, so SERM just means selective estrogen receptor modulator. So this would be considered one of those because, again, selective estrogen receptor, meaning different tissues express different varieties of the estrogen receptor, such that the one found in the breast tissue, in the nucleus of the breast tissue cells, is different than that in the bone. So that's why you can have those differences in activity. But we'll talk more about that in the OB-GYN section later on. Getting into calcitonin, this was an interesting one. So this is not usually recommended for osteoporosis kind of first line, but we'll see it has some effects in terms of hyperparathyroidism and calcium homeostasis. Typically, we're not going to be using this for osteoporosis first line, but maybe if they failed kind of other things, nothing else is really appropriate, this is okay. And so basically, this is a normal hormone that is released from the thyroid gland when calcium is really elevated. So basically, this is the opposite of PTH, right? So if you have high calcium levels, this would normally be released here, and that would then oppose the action of PTH. If you had someone who was in a hyperparathyroid state, you could administer this to try to sort of basically inhibit that and cause calcium levels to decrease by keeping less osteoclast activity going, right? Basically, you're going to be laying down more of that calcium into the bone, maybe getting rid of more of it out of the kidneys, but basically it's used to lower levels. So this can be used occasionally for hyperparathyroidism or hypercalcemia to try to lower those levels to some degree. This is kind of neat because, again, I like to identify animal sources for things. And so for whatever reason, we get this from salmon sperm. Like, again, who the researcher was that determined this, I don't know, maybe someone that just really loved working with salmon, but regardless, they discovered it, and that's where we actually isolate it from. This is also a med that's administered intranasally, which is kind of neat. Just from, we don't see a lot of intranasal medications used for non-ENT purposes. So that's kind of a neat route of administration for that. So the reason why we don't wait for Jackson to chime in, it'll happen, I'm sure. Anyway, so the big thing here, though, is that why we don't like it for osteoporosis is while it does help with like vertebral fractures, it really doesn't help for hip fractures. So we really want something that's going to be able to act really for everything. So that's kind of the thing we're looking for there. As I mentioned, we'll talk about this a little bit more in endocrinology when we talk about hypercalcemia. That's where you see it used much more frequently. And then we have a drug here called teriparatide or forteo. This is one's really kind of interesting. Again, I say all of them are interesting, but I guess I'm a pharmacist, so I'm supposed to. But I'm sure your opinions will differ greatly. This is another one, but I think the mechanism is kind of neat here. And someone had a question on this. But basically, this is used for patients who have like failed bisphosphonates, they couldn't maybe tolerate it, and they need something else to help reduce those risks for fractures. And so this drug is actually the 34 amino acids, basically it's the N-terminal end of parathyroid hormone. So parathyroid hormone I looked up is like 80 some odd amino acids long. This is like the end 34 amino acids. And so it has kind of similar activity. It's still able to activate those PTH receptors, right? And so you would think, well, wait a second, like parathyroid hormone, like it causes bone resorption, it causes calcium to be leached out of the bone. Shouldn't that decrease bone mineral density, right? And so if you look over here at this question on the sticky board, which I've been anticipating answering for the past couple of days, you say, wait a second, I'm curious. In Room, we learned that teriparatide is a synthetic version of PTH, correct? Just the end of it. And its function to move calcium from bone to the serum. However, teriparatide is an anabolic drug that builds bone. This is confusing because it seems opposite. I agree, that was confusing because it is opposite. But what it does is basically what you find is that chronic exposure to high parathyroid hormone levels causes that leaching of calcium from the bone. If you have intermittent or sort of sporadic exposure to it, that makes a difference because you'll find that PTH does not just cause osteoclast activity to go up, it actually helps overall with bone mineral density it does stimulate osteoblasts to some degree. So if you get kind of intermittent spurts of it, it actually increases bone mineral density. If you're chronically exposed to it, you end up getting leaching of calcium from the bone. You have more osteoclast activity. So you can get too much of a good thing. This is an example of that. So teriparatide is kind of like a sometimes PTH treat, and that will help to build up the bone there. Again, it's not perfect. You're going to find that there's a REMS program associated with this because there is an increased risk for bone cancer, and so they actually recommend taking it less than 2 years. So again, not ideal. This would be like second, third, fourth line kind of drug I'd be utilizing here for patients who are really at high risk for fractures. So basically, how would you go about doing this? And again, I'm not going to get super in the weeds in terms of looking at this. Probably should make it like a little bit bigger or something. But basically what you're going to see is that, let's say, you have a patient with a fracture. If they already have a fracture, they're probably already showing that they have some degree of bone mineral density issues here. So let's say like they weren't really following primary care very often and they get a fracture, they come in and they're like, okay, well, it's a 75-year-old lady who's, doesn't really follow care, but she comes in with a fracture. There's probably some degree of osteoporosis here. And so at this point, it's okay to go ahead and start therapy, at least with calcium and vitamin D. You also probably want to consider something like a bisphosphonate, always going to be first line in those cases there. For those other people who maybe you're following regularly, you're kind of monitoring them over the course of years, if you're in family practice, for instance, once they start to get to that age or they start to have some signs that they are kind of leading towards that road of having higher risk for fractures, that's where you can start to kind of consider doing your DEXA scans, which I'm not going to get super deep into all of that. But basically, regardless, you're probably going to recommend healthy lifestyle modifications, right? So again, make sure they're exercising, getting around, getting calcium and vitamin D supplementation either through their diet or through exogenous supplementation, which is probably going to be required. It's when they start to get more so into that point where where they have actual high fracture risk or actual osteoporosis diagnosed here is where you want to start to consider medication therapy. So you always do calcium and vitamin D, right? Because you can't really do bisphosphonate therapy without having the building blocks of that bone. And so you need the calcium there. You need vitamin D to help out with that calcium absorption and whatnot. So you got to have that going regardless. You get that going, and then also you want to start to consider adding on antiresorptive therapy like bisphosphonate most commonly, and if that fails, then you can start to kind of go down the line of considering things like teriparatide. Last line is probably calcitonin, just based on lack of efficacy and all of that, and that's where you go. So most patients will do well with a bisphosphonate. It's only occasionally you got to kind of switch it up and go kind of down the line there. So just something to consider. Hopefully that makes a sense. See, how often would you dose forteo in those 2 years? Well, we can look it up. Let's do it. Oh, I actually already have it up. That's fantastic. I was looking it up before class. Want to make sure I had all my ducks in a row. So dosages, let's see, adult. Osteoporosis, glucocorticoid induced. Let's just do regular treatment. 20 micrograms once daily. So they would get 712 doses. Is that right? 356 times 2. Yeah, but if you look at the black box warning, where's it at? Oh, why that's not there. There should be one. Deep bone, cancer. I'm really going off the lines here. Oh, why stuff's not coming up here. Anyway, there is a RIMS program for this. I'm not sure why it's not showing up in Lexicon, but regardless, that's off the beaten track here. So we'll continue on regardless. But thank you for that question. Okay. So any questions on osteoporosis? Pretty straightforward. Nothing too tricky there. Really just make sure that when you're educating, they're taking the bisphosphonates correctly if they're using the oral form. Got to stay upright for 30 minutes. Just take it with a glass of water and don't ingest anything else for another 30 minutes. Okay? Do it in the first thing they wake up in the morning is most easiest way to do it, I guess. Okay, now let's talk about the gout here. So what is gout? Basically, is these manifestations of hyperuricemia. Typically, you're having precipitation of monosodium urate crystals in the joints, right? Isabel saying, I think it was osteosarcoma. Dr. O said it would appear in animal studies. Okay, yeah, so and I know there's a RIMS program for it. I've looked it up before, but again, Lexi did not have that on there, so I'm not sure if that's changed or what. Yeah, so someone's asking, could you explain the MOA for teriparatide again? So again, you're gonna when you think of parathyroid hormone, you really kind of, I think most of us think about it in simplistic terms of causing resorption of calcium from the bone, because that's the main action it does, right? You have low calcium levels, PTH gets secreted, and it raises calcium levels by increasing reabsorption from the kidneys and getting it from the bone. But it also has some other actions in there too. So it does have some anabolic actions on the bone. In terms of like stimulating osteoblasts to work and things like that. So there is some anabolic and catabolic activity with it in terms of its exposure, its actions on the bone. What you find is with patients who are chronically exposed to high levels of PTH, so hyperparathyroidism due to kidney dysfunction, whatever the reason is, that is going to be leaching. It's going to lend the balance more towards leaching calcium from the bone and causing osteoporosis. That's a chronic exposure to high levels of PTH. If I were to just give someone daily spurts of it, it tends to favor the osteoblast activity and cause anabolic actions to grow the bone. And again, that's why that risk for osteosarcoma was there, is because it's stimulating the bone. If you keep stimulating those tissues, eventually they may mutate to the point where they just become cancerous. So that's where we're getting it at. So it's kind of giving you a daily spurt of PTH activity, which favors anabolic actions versus chronic exposure favors catabolic actions. That makes sense. Some said, when would you consider adding Prolia to therapy? When is it in the hierarchy of treatment? So if we go back to looking at this, let's see, where do they put it at? So they kind of talk about it as being possibly first line. I would probably consider it, and I guess my big head's in the way, so that's probably what the problem is here. Let me raise this up some. Anyway, so I'd probably consider denosumab when, it's going to be more expensive. It's a monoclonal antibody, so if they could not tolerate a bisphosphonate, then I would say that's when you kind of use that as an alternative first line agent. Or you could use it as maybe a second line if they realize, maybe bisphosphonates are not for them, does not work out that well, whatever the case may be. I hope that makes a sense. Just got to consider my big head can sometimes get in the way. But all right. Okay, so anyway, talking about gout, we have these monosodium urate crystals that are precipitating out in the joints, causing a lot of injury there. But certainly other things can happen too, like uric acid nephrolithiasis. You can get interstitial renal injury as a result of this. Um, and so we got to understand, like, where's all this uric acid coming from, right? And so basically, what happens is that when we're degrading purines, like what we'd see in RNA and DNA, uric acid is going to be a byproduct of that. It's a waste product. And we're going to find that there are several enzymes that are responsible for forming uric acid, as we're going to see here in just a little bit. We're going to find that you can have either two problems here. You can have overproduction of uric acid, or you could have underexcretion of it. Overproduction is typically either due to things like enzyme abnormalities. If you have increased breakdown of nucleic acids, this happens in cases of things like a treatment for certain types of cancer, like leukemias. There are patients who can develop what we call now the name totally escapes me. Tumor lysis syndrome. That's what I was thinking of. Tumor lysis syndrome, where if you have someone like a really high white count, and then you give them chemotherapy and start to kill off all those cells, all that DNA breaks down, or it gets broken down and forms a lot of uric acid. So that actually is a big risk for kidney injury in patients receiving chemotherapy. Or you could have excessive cell turnover. So again, myeloproliferative disorders like cancer can do that as well. Those are one way you can see it. The other way would be under excretion. So either their kidneys are not processing it out enough on its own, or dehydration. You're dehydrated. You're going to be concentrating all that uric acid, increasing the risk for it precipitating out, basically. Okay. So, and again, they always talk about, you think about patients having like, high or like red meat diets and things like that. Imagine all the cells you're consuming, those muscle cells, and that high meat diet, is going to have, a lot of breakdown of the nucleic acids. That's why you always, they talk about gout being a rich person's disease back in the wee olden times, when you'd have, I always love those like really old school pictures of people drawing people suffering from gout. They have like a little devil poking someone's like big toe. But so it's one of those things where it's either an issue of overproduction of uric acid, or they're just not getting rid of it quickly. So some of it could be a supply issue in those cases. What do we want to do for these patients? Obviously, terminate the attack because it is quite painful for them. And if we can try to prevent episodes of arthritis, that would be good as well. So we'll see that our therapies are mainly going to be focusing on either anti-inflammatory actions or trying to use what we call urate lowering therapy. Okay. So for acute gouty arthritis, mainly going to be pain management here. In terms of like non-pharmacologic stuff, like ice can be useful here, but for a lot of times medications are needed. So NSAIDs are going to be usually a cornerstone of therapy for these patients. Any NSAID will do. Let's see. Oh, it's funny. I'll have to check that out. I've not watched that show before, but I do like the Matt Groening and all those people. But with NSAIDs, you're going to find that any of them will work, but the same caveats apply. So if they have like a high risk GI history, like maybe use something that's more COX-2 selective, like celecoxib. Meloxicam, we'll talk more about that in the upcoming section. Corticosteroids are utilized occasionally for especially painful events. This is typically short course. And we'll talk about colchicine briefly as well. Typically, you want to start therapy pretty early, within 24 hours or so. You get a little bit better effects in terms of reducing symptom duration and all of that. And then we will talk about using combination therapies more frequently when we have either like really severe pain or if they have multiple joints all being affected at the same time. So we're going to talk about NSAIDs in our pain management slides. We'll get to that. Normally this lecture comes a lot later, but that's okay. And so we'll get to that more specifics in terms of all the different NSAIDs we're going to run into. In terms of corticosteroids, these will be pretty equally efficacious to the NSAIDs. Actually, what's kind of nice too is we can utilize either the traditional oral corticosteroids, or we could actually do an intra-articular injection occasionally. So something like triamcinolone or Kinalog can be utilized, especially if it's just like one joint in particular is being affected. I was thinking about the great toe being affected, but I don't know what's so great about it if it's always getting gouty attacks. It's just like it can't be that great. But if it's going to be more than two joints, traditionally systemic therapy is going to be required in that case there. You guys don't have to pretend to laugh at my jokes. It's totally okay. I can't see you all, so I just assume you're all dying of hysterical laughter. But again, if you're going to be on steroids for more than a week, remember to consider building in that taper there, right? The colchicine is kind of a new one here that we're talking about. This, if you think back to your oncology lecture, which I'm sure most of you try to repress at this point. But try to open up that memory a little bit. And if you recall, we were dealing with like vinca alkaloids and the taxane drugs and how they were antimitotic drugs because they inhibited basically the microtubules from functioning appropriately. Colchicine kind of fits in that same category. So we consider this an antimitotic drug and basically is trying to prevent replication of these white cells, which are causing a lot of the inflammation and injury in gout. And so also by inhibiting microtubules, because microtubules are not just used for mitosis, but they can also inhibit cell migration, right? They're utilized as forming the cytoskeleton and causing that locomotion. By inhibiting that, then you can prevent some of the neutrophils from getting to the site of action, okay? Really, colchicine's main use is going to be for gout. It's a very old drug. It's been around for a long, long time. And still used occasionally just for this purpose here. Usually if it's more than 36 hours after the onset of symptoms, it does lose some efficacy, but most patients will probably seek care before then anyway. Now, note there's a lot of nausea, vomiting, diarrhea associated with this because not only can it affect the neutrophils going to the site of inflammation, but it can affect your GI cells as well, just like any cancer drug might. And so you can find that and actually the old dosing paradigm for colchicine used to be you dose until you threw up, and then that was your maximum dose. And so it's kind of a funny way to dose things, just so keep going until you throw up and then you're done. It's like, I don't know, like college drinking schedule or something like that perhaps. But regardless, a lot of nausea, vomiting with this. You probably want to give some Zofran along with it just to try to mitigate some of that. But if you're having too much on board, you're having people taking it chronically, you can run into risk for having myelosuppression. So you can see some neutropenia, and actually some neuropathies have developed from this drug as well. So I don't really like colchicine that much, especially when an NSAID would probably do just as well in a lot of cases, but some people swear by it. Obviously, I logged in late. Shame on you. I'm just kidding. But regarding the vitamin D thing, 25-hydroxylase, CYP3A4 converts ergo and cholecalciferol to 25-hydroxy-D. So I'm thinking interactions. That's a funny thought. I don't know of a ton of clinically important interactions that come about from that. So yeah, I don't know. It's interesting. I've not thought of any. I've never seen any clinical situations come up or seen recommendations that say if you have this interaction on board that I might run into some problems, but it's a good thought there. I've not thought about that. Anyway, so basically when you're looking at these patients here developing gouty arthritis, for more mild to moderate cases, I was about to say sub-moderate, mild to moderate cases here, typically monotherapy is going to be good here. So your NSAIDs, colchicine, systemic corticosteroids, I'd probably go NSAIDs most of the time. And think about it too. When we get into the pain management stuff, we'll talk about different routes for NSAIDs. But if they're coming in to an urgent care or an ER, they probably want something done, right now. I'd probably give them an IV NSAID, like Toradol or something like that. That'd be a pretty good way to knock down that pain quickly. If they're at home or if they were in a setting where they couldn't really get IM or IV medications, oral ibuprofen, naproxen, any of those are totally fine, right? In terms of how they do after that, we'll talk about some urate lowering acid therapy to try to prevent future attacks. But on the other hand, having really severe cases here, this is where you can utilize combos. So you can use colchicine plus an NSAID, colchicine plus oral corticosteroid. You also want to consider your intra-articular steroids if it's a limited number of joints, probably no more than 2, I would say, and then see how they're doing based off of that. That's going to cover 99% of the patients you're going to run into. I've never ever seen someone require interleukin-1 inhibitor therapy, so I'm not even going to talk about that because it's such a sort of fringe case there. However, I do want to talk about ways that we can try to prevent recurrent attacks by lowering uric acid levels in the first place. Someone's saying, due to colchicine's GI effects, would you ever want to choose a selective NSAID to use with it? Probably not, because if you think about it, with a selective NSAID, with a non-selective NSAID, the problem's a chronic one, right? It's not like I give a single dose of ibuprofen and that a gastric protective barrier is compromised at all. This is more of a chronic thing. So if I had a patient who never routinely took NSAIDs and they came in with an acute gouty attack, those are so severe, I give them colchicine and non-selective NSAID, it's not going to matter, right? However, if it was someone who had a history of peptic ulcer disease or they chronically took NSAIDs, then I might make the switch. to go to a more selective one, but it just depends on that situation. But for most times, I'm not going to necessarily pick one over the other just because I'm giving colchicine at the same time. That's a good thought, though. It's just that colchicine is so like directly irritating to the GI tract because of its activity. And in fact, actually, like colchicine overdoses, like which are exceedingly rare because it's not a common drug we use nowadays, but are quite fatal. And it's actually not even a quick fatality. It actually takes usually like weeks because you more so die from the neutropenia and secondary infection. So not great. Let's see. You said NSAID is number one rather than colchicine. I think rheum it was the opposite. Someone else said in rheum we learned that colchicine is first line, but in ortho we learned that NSAIDs are first line. Which one is the first line treatment for acute gout? I don't know, probably whatever your teacher told you for that particular test is what I would say as a first line. I just think that my personal standpoint is if you look at it from an efficacy standpoint and a toxicity standpoint, I feel that NSAIDs are probably going to come out on top if you were to compare the two. Not to say that colchicine is a bad choice. It's just probably not something. If I was having an acute gouty attack, I'd be like, give me some Toradol first. Colchicine is just, you hear about all the nausea, vomiting associated with it. You feel probably even more miserable. At least give some Zofran or something along with it to make sure they're not going to have too many issues from that standpoint. So from a school standpoint, whatever the teacher says is first line, I would go with that. On my test, if I were to ask you which one of these is first line for a gout, I'm not going to make you choose between the two. That'd be ridiculous. But I may ask, hey, the patient already took this. What would you want to add on to it? What could be a good add-on agent? And they took colchicine already, well, maybe a steroid, maybe an NSAID, so, or if I say something like, the patient has just one joint being affected, what could you use? Like, well, you can use an intra-articular steroid, but if I said they have 3 joints being affected, well, then intra-articular steroid wouldn't be a good option there. So I'm not going to get that granular in terms of what I would ask on the test. However, though, each teacher is, different than me, and so whatever they say is first line for them. So that's my 2 cents. Although my mind is easy to change if presented with new data. So anyway, okay, getting into the hyperuricemia here, you're going to see, and actually, actually think about it, like if you go to most ERs, like, and that's I always go back to the ER setting because that's my natural predilection. But you're going to have an easier time getting a hold of NSAIDs than colchicine probably. I don't know how much colchicine is going to be kept on stock for most hospitals, but I haven't been in an adult hospital in a while. Interesting. Why is Indocin the preferred NSAID for gout? Usually, history and clinical inertia. Sometimes certain drugs get touted as like the drug of choice, and not that it's backed by any evidence, but more so just by that's what people have done for a really long time. So they say if it's not broke, why fix it? And so you can do Indocin, but really there's nothing special about it. Any of them will work just fine. I'm not aware of any data that says Indocin is working better. Yeah, I don't know. I'm not sure if I've ever seen any head-to-head trials. Not that it's easy to do those kind of trials necessarily, but yeah, if they had multiple joints, I'd end up doing systemic corticosteroids. Again, so the other thing too I want to make a point of, and this is not to say anything about any other teachers, because I think it's important to get different perspectives on things, but two, like you want to think about it from a practicality standpoint. If I go into a typical ER setting, and this is clinical context you're going to get when you're working, so your experience may vary. But when I think about going into an ER, I know I can get ibuprofen, Toradol right off the bat, no problem. It's going to be there in the Pyxis. We can get it, no problem. Whatever, medicine cabinet they use. Indocin is not used as frequently, just in general in adult medicine, so it may be more difficult to have on hand unless someone specifically requests it. Colchicine, it's a very limited use case. And if I'm a hospital administrator and I can get away with using NSAIDs, which are dirt cheap, instead of carrying colchicine, which is probably also cheap, but it's just more drugs to carry, just go with the NSAID. So there's a lot of give and take. And again, your experience may totally vary from mine. Totally possible. But again, I'm just trying to think about the common things that I see when I'm working clinically. So again, I don't see a lot of kids with gout anyway. Although you can see kids with the hyperuricemia due to some of their particular issues, which I'll get into in just a moment here. So, but again, if a teacher says something for their particular class is first line, then that's what you need to know. Kind of The thing with having different teachers do different classes just is what it is. But regardless, with hyperuricemia, we want to do things to try to keep those levels relatively low overall in order to maintain or try to prevent attacks from happening here. So doing things like limiting alcohol intake, right? Alcohol is a diuretic that can cause contraction of the blood volume, causing increased concentrations of uric acid. If we could limit medications that also raise uric acid levels, so things like niacin, thiazide and loop diuretics, again, those cause that volume contraction there. Low-dose aspirin has even been known to increase uric acid levels to a degree. So you have to take it with kind of a grain of salt. If they need to be on low-dose aspirin because they have a history of heart attack, well, then I'm probably going to go ahead and just try to keep them on the aspirin and do something else to deal with the uric acid levels, whether it's with diet or something else, right? But let's talk about the pharmacologic therapy we can use in order to lower uric acid levels. We have a few agents here. If patients have like 2 or more attacks per year, then it's probably a good idea to put them on preventative therapy at that point. Also, we can consider if they have like a history of urolithiasis, chronic kidney disease, the patients that are more likely to develop those like kind of more serious kidney manifestations of it. And so a couple things we can do here. One would be to decrease the synthesis of uric acid. So if I can produce less of it, that's one way to do it. Or I can increase the excretion. So the main way to decrease synthesis is going to be with our xanthine oxidase inhibitors. And then ways to get rid of it are going to be the uricosurics, which makes sense. So uric peeing, uric acid kind of makes sense if you look at the name there. So this is a very complicated way to see how purines get broken down into uric acid. So this is a tough thing for students to memorize, and that's why I don't make you guys memorize it. So don't worry about that. Whole point being is it gets complicated with all your nucleic acids and all this stuff here. But guess what? The main thing you need to know is xanthine oxidase. This is an enzyme that will take hypoxanthine and convert it down into eventually uric acid. If you inhibit this, it doesn't matter about all this other stuff. It's way more water soluble. You can pee it out, no problem. It's the uric acid that's a problem. So if I inhibit this enzyme, then I get less uric acid. I'm less likely to have a gouty attack. Okay, that's the baseline. Just throw that in there to scare people, just to tell them they don't need to memorize it. But anyway, so by giving a xanthine oxidase inhibitor, you'll inhibit that enzyme and you will produce less uric acid. That's all I need to know. And this is going to be the most widely used forms to try to prevent uric acid formation. These are the best way to prevent gouty attacks is this mechanism here. We have 2 available here. We have allopurinol. This is a very old drug. It's been around for a really long time, so most patients will probably be put on this. Some patients may be on the newer drug called febuxostat or euloric. With allopurinol, there is some risk for things like Stevens-Johnson syndrome, toxic epidermal necrolysis. So this would be just like with like Lamictal. You would tell people, hey, look out for blisters, rashes, ulcers, things like that. This would be the same thing with allopurinol. Not common, but it can happen. And there's some risk for things like leukopenia you would want to watch out for. Febuxostat is going to be newer. It's more expensive. We have less experience with it, but overall maybe a little bit better tolerated by some patients. But you do want to watch for liver dysfunction when using that drug there. But both of them work pretty well in order to get uric acid levels down. Okay, so the other way we can do this is with uricosuric drugs. And so this is less often used, I will tell you, very infrequently. But basically, by blocking reuptake of uric acid in the kidneys, you can actually have an easier time just urinating it out, basically. And so a drug here is called probenecid that can be utilized here. But remember, if you block the reuptake of the uric acid, more of it is in the renal tubules. And if that concentration is high enough, then it's going to precipitate out. And so I'm not familiar with that. I might have to look that up. It wasn't like one of the more common things on there, but yeah, I'm sure it's been reported if you see that there with the febuxostat. But with probenecid, again, if you prevent reuptake of the uric acid, reabsorption of uric acid, it's going to be out in the renal tubules, more likely to precipitate out, which is why you see about a 10% chance of nephrolithiasis. Not great, which is why we don't use it frequently for this. And interestingly enough, it can actually cause an acute precipitation of gouty attack, which is also not great from that standpoint. But we actually used to use it back in the day, back before we had like synthetic means of generating penicillins and cephalosporins. We used to give this in order to make it so cephalosporins and penicillins had a longer half-life. And so that way you can get more bang for your buck out of a single dose of penicillin. This is like back when penicillin was like brand new, because it prevents the elimination of it through the kidneys. So kind of interesting, but would not use this with anyone with like renal impairment, anything like that. So this would be definitely second line to uric acid lowering drugs there. So this is an interesting drug. It's called rasburicase or Elitech. This is actually a recombinant form of urate oxidase. So if you have someone who is basically having huge cell turnover, most often I think about this in the case of initiating treatment for certain types of leukemia in children, because that's what I run into most frequently. Basically, by initiating chemotherapy, you start killing off all these white cells. All that DNA spills out, all of it starts to get metabolized to form uric acid. So it's very likely that you can cause significant kidney injury in these patients there. And so this is something called tumor lysis syndrome that you can see. And then again, that's why we will frequently have some of our chemo kids, I should call them that, but our kids with oncologic indications will sometimes be put on allopurinol in order to prevent uric acid levels from rising. That's why I see a lot of kids that are on that or for that purpose. Rasburicase, though, is like an emergent kind of medication that you only give in case you have really severe, potentially kidney-threatening levels of uric acid due to the cell turnover. And actually, it's very, very expensive. I can't remember the last price I saw for it, but it was quite expensive. And we have to go through this whole, criteria just to make sure that we can even utilize it because it is so expensive. But basically, it cleaves that uric acid and forms it into a more water-soluble form. So that's why you can just urinate it right on out. Actually, just going to try to find the cost here just so I can kind of impress upon you how much it actually is. Actually, it's not too bad anymore. Used to be more expensive. Now it's like about $5,000, $6,000 per dose. That's actually not too bad as compared to some stuff. That's a lot of money, but not for like a hospital. But anyway, one kind of unique thing with this is that you can induce hemolysis and methemoglobinemia in patients who have a G6PD deficiency. And this is not something you're going to know in a lot of patients unless you test for it specifically. But basically, this is an enzyme deficiency that makes it more difficult for your cells to deal with oxidating agents. And so you can develop methemoglobinemia, which basically turns your patient blue if you weren't familiar. It's a pretty interesting disease state, which we can talk about later. But another thing too is patients that get multiple doses, they can develop antibodies against it, which may increase risk for allergy. So it's not something we give very lightly. Make sure they really have a good need for it before we use it. So looking at this, typically does a patient have an indication for urate lowering therapy? If yes, then certainly you want to consider having medications available to them for when an acute gouty attack actually happens. So, and also when you're initiating urate lowering therapy initially, there is some risk that you could actually induce an attack. So that way you can give them something, they have something available to them to treat those gouty attacks if they occur. So they might have some as needed indications for this. And then looking at the actual urate lowering therapy, typically you're going to go with allopurinol or febuxostat first line as an alternative. Then probenecid can be used there. Okay. For some patients, you may find that they are going to be on prophylactic therapy in terms of like using an NSAID or colchicine in some cases, but it's pretty rare that you see that done unless they are really uncontrolled otherwise. And then you're monitoring the uric acid levels, make sure they're getting into line, talk about their diet and all of that, get things under control there. So that's kind of what we're going to be looking at. Let's see. Kaylee's asking to clarify, it's given in extreme cases to prevent kidney complications or can cause. So it's used to prevent the kidney complications. All that uric acid is being formed, spilling out, and is going to flood the kidneys and precipitate out. That's what we're trying to prevent because that can be potentially permanent renal dysfunction from that. Ooh, I like your colors on your sticky note here. Could rasburicase also use uric acid to precipitate out of the renal tubules? No, because the uric acid gets cleaved into a more water-soluble form. So if you go back and look at the other slide here, you can see that it catalyzes a breakdown of uric acid into soluble allantoin. That is not going to precipitate out. It's not going to cause any kidney issues there. So that's good from that standpoint. Good thought, though. You explain why probenecid inhibits renal secretion of penicillin and cephalosporins. So basically, some drugs undergo just filtration through the glomerulus. Some drugs will be secreted into the renal tubules. Probenecid inhibits that. It inhibits that such that you're able to keep more of the penicillins in the system for longer. We don't do that anymore because now we have easy access to penicillins and cephalosporins because we have synthetic means to do it. Back in the day, we used to have to like go into people's like college students' fridges and have to harvest the penicillin out of the back of it every semester. I'm just kidding. But we used to grow it from the actual fungus itself, so it was more difficult to acquire. And so that's why we were trying to find ways to make it last for long, right? All right, so any questions on that section? If not, I'm going to switch gears and go to the next one. too much time talking on this stuff. Let's start speeding it up, right? All right. So next up, we're going to talk about orthopedics and pain. This is really just my way of talking about pain management. There's not a lot of ortho-specific drugs you're going to run into in pharm. I apologize for my metal straw in my metal cup. Not a good idea. Anyway, let's talk about pain management. This is a big deal, and please, if you want to pipe up with anything from your substance use education, that can be really helpful because we're going to talk about some of that here. But this is a huge reason for patients showing up and come to clinics, come to ERs, etc., because they're in pain. We'll talk about management of acute pain versus chronic pain, but we know this is something that affects a huge number of people and has a huge loss of, loss of money due to not being able to work, to produce things, huge in terms of like quality of life issues, in terms of both physical and psychosocial effects, so this is huge, right? The question is like, well, why is it difficult to really get optimal pain relief for these patients here? And there's a lot of factors that go into it, both on the patient side and on the provider side, right? And so this is where I want to try to, keep you guys from getting too jaded, because I think it's really easy, especially when, you're fresh out of school and you're wide-eyed and bushy-tailed. It's easy to kind of get ground down and kind of get jaded to a lot of this stuff. But I want to try to keep that from happening too much if I can, even a modicum, because it's so important these patients get taken care of appropriately. And so you can be a really big help for that and be a good advocate for your patient. Anyway, so related to the patient, like, why do they not want to take appropriate measures to control their pain? Well, they could be really scared about things like addiction. They might be worried about, they may have a family member who's addicted to pain medications. They could be worried about side effects. But from a healthcare provider standpoint, a lot of us don't get a lot of formal training. Like that PAEA thing you did is like brand new. Like only 20 schools in the whole US have done that. And that's something that's huge, because we're giving you extra education, extra context, try to take good care of these people here. There could be concerns from like governmental crackdown that if you're prescribing too much, you'll get put on the naughty list. Fear of getting your patients addicted. Like, why would you want to do that? Like, it'd be awful to have somebody become addicted because of what you did, right? So a lot of concerns from every side. And then we just don't have enough like good like pain practitioners. Like insurance doesn't cover it appropriately. So you get poor reimbursement. That you may have lack of available providers, lack of available medication. A lot of issues with this, right? Usually you're going to find for like pain management, like unless you're doing invasive techniques like pain blocks and things like that, like you can't bill for a whole lot, right? Because again, a lot of it's just medication management, not doing a whole lot of procedures, and that's where all the money is, right? But anyway, you've probably learned a lot about pain, talking about doing pain assessments and things like that. So I'm not going to get too in the weeds here. But what is pain? It's kind of whatever the patient says it is, right? It's a very subjective thing, and it can be quite variable. It can be variable in terms of time of day, onset, severity, all kinds of things. And again, it's hard to say, because you think, a patient comes in and they say, oh, I'm 8 out of 10 pain. And you go, well, you're just sitting there and you look pretty comfortable. I'm an 8 out of 10. That could be it. That could be that patient's at 8 out of 10, because maybe they've been living in that pain so long that they just are kind of dull to it. They just don't show those outward manifestations. Versus someone who has like, an open femur fracture and they're screaming in pain, they're probably a 10 out of 10. It's pretty easy to tell. So pain is not always easy to be able to detect. And if you can come up with an objective way to determine it, then boy, that would be a good way to make some money. Let me tell you what. But when dealing with pain, we're going to mainly focus on treating both acute and also chronic pain, right? And so we know pain comes and goes. We know that it can change time of day, the activity the patient's experiencing, all these different things. We also know there could be different etiologies of pain too, right? So not all pain is treated the same because the etiology is different. So visceral and somatic pain can be treated one way, whereas neuropathic pain we'll find can be treated totally differently, as we'll see. So, and again, when talking about acute versus chronic, acute is like stuff we can predict. Like, okay, you have post-operative pain. It'll probably last a few days and then you're done, right? We'll see that primarily analgesics is going to be the way to treat this, and that makes sense, and that's why we do it that way. But for chronic pain, it becomes more of a complication. It becomes more difficult, because this is something that may last forever, right? You may not be able to get to a point where you can completely reduce that patient's pain down to zero. It just may not be possible. And so because of that, we need to make sure that we're using multimodal therapies in order to help manage that pain. So we need to make sure that we're not just relying on opioid analgesics. We need to look at things like PT and OT. We need to look at things like non-pharmacologic therapy. We need to look at herbal supplements. Who knows? Like there's lots of things out there that could be useful, and we need to try to address all of them, because if you just say give them an opioid, you're going to be limiting yourself to a big degree there. Okay. Anyway, you guys know the difference between nociceptive and neuropathic pain, how it's expressed there. Again, neuropathic pain is more due to a nerve issue. So opioids don't necessarily treat the nerve issue, and so that's why we're going to be using different modalities in order to treat that. We'll talk about some like antidepressants and different things like that as we go forward, right? And again, we know this is a huge cost, huge burden on quality of life, just being in pain constantly. It takes a big toll on you from a psychological standpoint for sure. Lack of ability to get around, do the things you want to do, huge in terms of impacts on quality of life. So anything we can do to fix that is going to be beneficial. So how do we optimally assess pain? You guys know how to do this already, but I'm going to give you a few just little perspectives from my end. Not that I'm sitting there assessing pain all the time, but I can at least, give you a few things that I've seen or things that I do when dealing with patients. But anyway, you guys know about talking about onset, location. I'm not going to get super deep on that. Talking about the characteristics, because that kind of leads you to choosing, okay, well, do I think this is more neuropathic? Do I think this is more visceral, etc.? What I do want to kind of mention here is talking about pain scales. You guys don't have to look at this video, but if you want to, it should still work. But this is kind of a funny clip of a guy talking about he was in pain, going to the ER, and he's trying to figure out the right number to tell the doctor in order to get pain medication. He didn't want to say a 10 out of 10 because he thought they would think he's pain seeking. He didn't want to say too low of a number because he'd just get Tylenol. Finally settled on the right number. So you can look at that video if you like later on. But, you think about your typical pain scale and you think, okay, on a 0 out of 10, 0 to 10, what's your pain right now, right? I usually like to give descriptors too. I like to say, okay, so 0 is no pain, but 10 is, sawing your arm off with a dull, rusty spoon. They say, oh, I'm a 10 out of 10. I go, so you feel like your arm's being sawed off with a dull, rusty spoon right now? They said, yes. I said, okay, that's all I can go off of. That's what you're telling me. But there's other means for assessing that pain too, right? And so it's important to kind of consider other options. So I kind of like this 10 centimeter visual analog scale. This is kind of neat because patients can't get locked down to a single number. They have to kind of guesstimate where they want to put their pain down as, and then when you go back and give them pain medication or something, kind of come back and then reassess, they can't just point to the same spot as easily. So there are more chances for them to be a little bit more candid in terms of expressing their pain. But it's one of those things where people can sometimes be really tied to their number, and so this is something my wife saw frequently in her residency where she did pain management just for the VA. And so you'd have these older vets who have these really chronic pain conditions, and so some of them were like super stoic, and even though they were in excruciating pain, they're like, I'm a 3 out of 10 because that's what tough guys do, right? Or you'd have patients who, they would get so tied to their number that, they'd come in and say, okay, what's your pain? On a scale of 0 to 10. They say, I'm a 6. Say, okay, so they do some things to modify their medications and do this and that and the other. And they come in the next day and say, well, how do you feel? And they go, oh, I feel so much better. I'm able to get around a little bit better. And so what's your pain on a scale of 0 to 10? They go, I'm a 6. Like part of that becomes their identity a little bit. And so it's hard to kind of get them disassociated from that number to get better ideas of what their pain's really doing. That's really something you're going to see more on the chronic end of things rather than on the acute pain scales. There's other ways to do it for geriatrics, for pediatrics. I'm sure most of you have never seen a mercury thermometer in your life. I've seen very few, but that's one way for elderly patients to perhaps identify and kind of associate their pain. For kids, very difficult to determine, to what their actual pain is, but they can point to a picture that best describes it. That's just right. So also, and this is really important too, is like figure out what works for them and what doesn't work, especially from a medication standpoint, because you'll have people that will, they come in, they say, oh yeah, I'm having my migraine. I always get Toradol, Compazine, and DHE, get Migranol. And that's okay. Someone donated a mercury thermometer. I hopefully got rid of it because it's probably not good to keep around in case it breaks. Mercury's not great to the brain, apparently. But, try to figure out what they've used before, what's worked for them, what hasn't worked for them, because if you try to give them something they've already had that doesn't work, they're going to laugh at you. Like they're going to say, well, this guy or gal does not know what they're doing. And so also, take into account adverse effects and things like that could, while a drug may work great for their pain, they felt miserable taking it because of constipation, right? Different things like that could make it not a good option in the future. And again, too, don't get so tied into what the pain scale is. Tie into like what their capabilities are. So, okay, yeah, they still say they're a 4 out of 10 after I initiated this new medication, but like they're able to get around better. They can do the things they want to do. They went back to work, whatever the case may be. Utilize that as another tool to say like, well, how well is my medication working? And document that, because that's really going to be important too over the long term. Kaylee's saying in the pain clinic, we had to make sure to document their pain scores prior to taking medication and after in order for them to get proper coverage for their medications. Yeah, so before and after. So follow-up assessment's super, super important too. Even if it doesn't change, at least you can document that, okay, well, I gave them a dose of morphine and went down from an 8 to a 6. So at least you can document that, yeah, you had some improvement. Because again, not everyone's going to get down to a 0, especially for chronic pain issues. You may, living at a 3 may be awesome to them because normally they're sitting at a 7. So anything can be an improvement based on the patient. That's why you have to really communicate with them and figure out a plan that's going to work for both of you, right? So also other things, look at their medication history, look at anything they're on that could be interacting with new therapies you're going to be introducing. Obviously your physical assessment is going to be huge in terms of looking for particular areas which may be painful. And then labs are important too. Looking for organ dysfunction, renal dysfunction, hepatic dysfunction may lead you to choosing one drug over another. And then history of substance abuse can be another big one, not just for themselves, but perhaps family history, right? Because we do know that with addiction, that there is a genetic component to that. You do want to be cognizant of that and just ask and say, okay, do we have any history of family substance abuse? And again, opioid abuse does not have to be the thing. It could be they have a history of alcohol abuse or anything like that. Could be kind of keying you in a little bit. This person may be at increased risk. Okay, and then this is super critical, and again, there's no test question I'm going to ask on this, but I just want to bold it just for I think it's so important, is to deal with the other psychiatric comorbidities. Because if you're in pain, easy for that to exacerbate your depression, which means you're just sitting around more, not doing anything, which worsens your pain, which worsens the depression. It's a sick cycle, so you've really got to try to interrupt that by making sure they're getting adequate care for that as best they can. Right? So when dealing with pain, it's important to consider that it's not just like an all or none phenomenon. Like patients can go through peaks and troughs of pain here. It's important to consider when giving medications that we need to cover for that as well. So what we want to think about, especially for more chronic pain, is to consider treating for the basal amount of pain they experience. And that's typically where we're going to use around the clock or long-acting medications. And then we have medications that are good for the breakthrough pain. Okay, so that way they may take something like OxyContin Q12 hours, so taking it twice a day for the around-the-clock coverage for basal pain. And then they have a prescription for Percocet, which is oxycodone and acetaminophen they take, say, every 6 hours as needed for breakthrough pain. That makes sense. Even though you're using the same drug in 2 different ways, it makes sense based on the modality for how you're treating that pain. Okay. Again, not to say everyone's going to require opioids, but just to give you an idea how you can use both long-acting meds on top of short-acting meds in order to help cover that. So if they take the long-acting med and not very active, maybe they don't need any breakthrough meds. If they get up, walk around, exacerbate some of that pain, that's where they're going to run into needing the breakthrough stuff. So there's different ways to approach this. A couple of different ways, like the WHO has a whole ladder about this, not the band, but the World Health Organization. You can also go via the etiology, right, based sort of approach here. The WHO approach basically is this ladder where you kind of start off with like non-opioids, like Tylenol, NSAIDs. Then you kind of step up your game a little bit and go to step 2 for some opioids for like to moderate pain. And then you go to even higher opioids for the really severe pain. It's not to say you got to start at step 1 and then go to 2 and then to 3, because that person coming in for that femur fracture that's open, if you start with like some Tylenol, say, here, try this Tylenol, see how it works for you, they're not going to be happy. So it's okay to skip some steps if it makes sense based on the patient's presentation and current pain that they're experiencing there. But just some things to consider. We'll get into all these meds here in a moment. But again, make sure that they have really severe pain, start at the top of the ladder and kind of work your way back down. So just to talk out first, we've kind of covered this to a fair bit already, talking about rheumatoid arthritis. But, let's talk about some of our non-opioid drugs first, get into our NSAIDs, Tylenol, all that, and then we'll kind of work into the opioids themselves. It's important to consider that there's different levels of the body that we can treat the pain at. Not all of them work at the site of injury. Some of them are going to work on the nerves along the way to get to the brain to give you that signal that, hey, ow, something hurts, right? So let's talk about where we can deal with the pain at the site first and then kind of work our way up through the spinal column and into the brain itself. So we know with inflammation, we talked about this already, all these inflammatory cytokines, you got cyclooxygenase going, you're releasing histamine and prostaglandins and substance P, all that good stuff. This could be due to trauma. It could be due to chemical irritation. It could be due to lots of different things that's releasing all this inflammatory cytokines causing this inflammation to occur, right? We know as soon as those leukocytes start kind of coming to the site, they're going to start releasing those lysozymes and all that good stuff. This is where you get more inflammatory cytokine action going on. And this is kind of a self-perpetuating system to a degree. The thing here is that a lot of these prostaglandins and whatnot, they're going to sensitize those pain fibers. They're more likely to send an action potential because their electric potential is being changed so that way they're more twitchy, they're more able to fire. And so if we can deal with that, if we can try to decrease the amount of inflammation, those pain signals are going to be less frequent. So less those nerves being activated to send the pain signal, the less pain should be experienced, basically, right? And so you can imagine here, if you're looking at the area of injury, say there's a cut or something to the skin, you can imagine here all these inflammatory cytokines being released here. It is sensitizing these fibers, which send that pain signal all the way up through the spinal column and into the brain to say, ouch, that hurt. Let me pull my hand away from that knife, or whatever the case may be. So really complex interplay here, which I'm sure Professor Kaplan got into with you with physiology. So there's a couple things we could do here. If we can decrease the inflammation, that's going to be one way to treat it. If we could try to maybe prevent those nerves from firing in the first place, there's drugs we can use to do that. Or if we can try to treat the signal coming up here and try to inhibit that to keep that signal from ever reaching the brain in the first place. So we're going to see with our different medications, there are different places they're going to be working at, which will make sense based on the dosage form we're using, some of the side effects we're going to see with it, etc. So this will all hopefully make sense here in a little bit. But in terms of anti-inflammatory activity, we know that by introducing things that block cyclooxygenase in particular, or maybe even like corticosteroids as an example, we can inhibit a lot of that prostaglandin leukotriene activity, so you get less vascular permeability, you're going to get less of those inflammatory cytokines being released, and hopefully less sensitization of those pain fibers, right? So we'll see again, prostaglandins sensitize pain fibers. That makes sense. We're going to see that if we can deal with that, that's going to be better for a more mild to moderate pain. Okay. And again, kind of think about the different drugs we're going to be talking about here and how their actions sort of differ and compare to one another. We've talked about COX to probably an absurd degree already, but again, just to kind of reiterate here, we're not really going to worry about reversibility or competitive nature of these drugs here. Reversibility really only applied to aspirin, which we know to be the main one that's an irreversible inhibitor, but for pain purposes, probably not going to deal a lot with aspirin. Again, if you look at a safety profile, aspirin has a tendency to be a little bit worse, so I'm going to mainly focus on the more traditional NSAIDs here. If you recall, we have COX-1 versus COX-2, COX-2 being the inducible one, that if you have that, if you have inflammation happening, that's going to be upregulated. COX-1 is constitutive, meaning that's what's helping to protect our stomach and whatnot, okay? So looking at the etiology-based treatment, how we're going to look at this, basically what you're going to see is that for more somatic or visceral pain, which is probably the majority of pain you're going to be dealing with, we're going to see that anti-inflammatory agents like NSAIDs and corticosteroids, also going to be a role for Tylenol a little bit, is going to be kind of the cornerstone, and then plus or minus opioids. For the neuropathic pain, because the issue is the nerves themselves, not any obvious site for inflammation, this is where we get into things like antidepressants, anticonvulsants, skeletal muscle relaxants. I'll talk about those a little bit later. And then plus or minus your opioids. Okay, so we're going to get into that more. So we've already talked about MS as an example of a neuropathic pain. We'll get into some others as well. So note that these are kind of parallel tracks here. You can't really use antidepressants to treat somatic or visceral pain and vice versa. NSAIDs are going to be limited in terms of utility for neuropathic pain, as we'll see. Okay. So looking at our therapeutic management pearls here, including both pharmacologic and non-pharmacologic modalities, this is tough because a lot of people do not want to use the non-pharmacologic modalities. They just want a pill to make the pain go away, right? May not always be super appropriate. But certainly for more chronic pain, you've got to consider all the behavioral issues. You've got to incorporate physical therapy, OT if necessary. All of that's got to be dealt with in addition because it's only going to be synergistic, right? You can't just do one or the other. And then our treatment here is to hopefully prevent pain. That'd be nice. To reduce it or ideally eliminate it. But as I mentioned, a lot of people are not going to be able to fully eliminate that pain. Going from a 7 to a 3 may be a really huge improvement for that patient and may be able to let them regain a lot of their independence, a lot of their functional capability, etc. Right? So again, treatment should be individualized. We always say that for everything, but based on the type of the pain, severity, the patient history. I'll give you an example here where a distant non-blood related family member had a history. He was born with a congenital heart defect that had been managed via surgery as an infant. He is now a 60-year-old some odd man. He has a history of substance abuse with opioids, and he had to go back and have a valve replacement done. You have to crack someone's chest open in order to get that valve replaced, and he has substance abuse issues. Like, so do you give him opioids or not? Like, there's a lot of considerations that go into that because this guy's in recovery. You don't want to, have him fall off the wagon because of the surgery that you had to put him under. So a lot of considerations here. We're going to talk about more in detail as we get to the kind of the specifics here, right? And again, everyone's a little bit different in terms of their pharmacogenetics. You may find variability in opioid receptors. Some people do really well with drugs like hydrocodone. Some people, it makes them sick to their stomach, right? You can't predict that unless you have experience with those particular agents, right? And again, multiple meds are often going to be required here. As much as I dislike using multiple meds, sometimes multimodal therapy with medications is useful. And again, if one therapy does not succeed, then okay, try something else. There's plenty of modalities we're going to see here that may be useful. Okay. So basically how we're going to go through this, we'll talk about Tylenol, our NSAIDs, opioids, and then get into our adjuvant medications, which is kind of the junk drawer of all the other stuff that we're going to talk about, like muscle relaxants and capsaicin and all that good stuff. Okay. So first off, I know we've talked about Tylenol before in terms of its use as an antipyretic. But here, obviously, we're going to be talking about it more for its pain and anti-analgesic sort of purposes here. Again, if you ever want to know where the APAP comes from as an abbreviation, it stands for the acetyl para-aminophenol, so APAP. Again, the Tylenol comes to the TYL here, and then the enol. So again, not the most imaginative sort of naming, but it is what it is. And again, note that this is not going to be a good anti-inflammatory drug. It's not going to have very good activity for that. So if you stub your toe and you have a site of inflammation, Tylenol may be able to deaden those signals coming up into the brain to some degree, but not going to be great for the inflammation you're experiencing. However, really good safety profile for the most part. This is why we like to use it first line for like low back pain, osteoarthritis, things like that, because it's so well tolerated by most patients. But for more moderate severe cases, this is not going to be useful. Okay, could still be used as an adjunct, as an add-on, but not going to be useful by itself. We do have some IV forms available, which most people are more familiar with the oral forms. But here we have Ofirmiv. This is actually really neat because it has been shown to have opioid-sparing effects. One of the big things you're going to see if you ever work in surgery or if you work in the hospital is that, especially post-op, you want to use as few opioids as possible because opioids are going to make the patient more lethargic. They're not going to want to get up, move around. Slows down the GI tract, so they're not going to be able to pass gas. Hard to tell if they have any kind of surgical ileus or something going on. So if you can use fewer opioids, they can recover faster and you can get them out of the hospital faster. Fewer infections, less cost. It's good overall. So anything you can use that's opioid sparing is very helpful. And so we actually find that by giving either like a preoperative or postoperative dose of Ofirmiv or an IV acetaminophen, that they have less opioid usage because they experience overall less pain and they get out of the hospital faster. So really good from that standpoint. And can be also useful for patients who can't tolerate oral or rectal medications. This could be a good alternative there too. Although if you're in the ER, don't be ordering that stuff. It's too expensive. We always save it for surgery at the ICU. I always have my ER doc say, "Can I get some of the IV Tylenol?" And I'm like, "Well, can they take it orally?" They're throwing up. Okay, well, use it rectally. Can I just get the IV? Do it rectally. It's fine. It's fine. Anyway, so looking at this, we're going to see that it doesn't really work at the site of inflammation because a lot of the peroxidases and stuff that get released by those neutrophils actually inactivate it. So that's why it doesn't have very good anti-inflammatory activity here. We don't really know why it works. It's not really quite clear there, but we just know that it helps to deaden that pain, helps as an analgesic, but is not good as an anti-inflammatory. Also, there's no GI side effects to really speak of as compared to NSAIDs. There's no renal effects, no respiratory effects, cardiovascular effects. Really well tolerated. So that's why we use it all the time as first line for a lot of more mild to moderate cases here. The caveat being that you can't use too much of it because you can obviously lead into having this hepatic necrosis, right? Typically, most patients, we're going to limit them to 4 grams in a day for adult patients. If you go above that, you're running the risk, even if you do it for a couple of days in a row, of having some degree of hepatic impairment, usually evidenced by some degree of transaminitis or ALT, AST elevate. There are cases where people will over-medicate themselves, not realizing it, and come in with fulminant hepatic failure. They come in yellow from head to toe, and they're in really dire straits unless you get the antidote on board and kind of support them through it. The liver's really good at repairing itself, but sometimes it needs a little extra help with some N-acetylcysteine, which, well, later on in the class. So the other important thing to consider is all sources of acetaminophen. So as an example here, say if someone was taking 650 of Tylenol every 6 hours, and then they're also taking hydrocodone, acetaminophen, 5-325 Q4 hours, very easy to see how they can get above their 4-gram maximum in a day very easily. And again, you may not know they're taking the Tylenol because they're taking the OTC form at home and they didn't tell you about it. You got to educate them and say, listen, do not take any other Tylenol on top of what I'm giving you because it can damage your liver. And if people have a history of liver disease, you want to make sure not to give them as much as well. I think down to like around 3 grams or so is the limit for patients with hepatic impairment. So if they have a history of alcohol abuse, hepatitis, anything like that where you're worried about their liver function, lower the dose down. Probably wouldn't use more than 3,200 milligrams for them. And again, watch that pretty closely. Okay. Good drug, but again, that one limitation is important. So, well, that was not loud. Getting into the NSAIDs, these are good because they have analgesic, antipyretic, anti-inflammatory activity. We know we have several available. The acetaminophen is a lot of cold drugs too. And a lot. Oh yeah, that's another. That's important, Kelly. So it's in a ton of cough and cold medication. So consider all their sources because they can get multiple sources. Very easy, not even recognize that. I'm starting to see more packaging that says very explicitly contains acetaminophen. But someone's like, oh, I'm going to take some acetaminophen, and then I'm going to take some Tylenol. They don't always equate that those two are the same thing, right? That's why brand names can be a little tricky there. I'm going to take some NyQuil along with some Tylenol because my head hurts. Both of those contain acetaminophen, right? So it's very easy to double up without them knowing. So the NSAIDs, recall, we have the COX-1, COX-2. Majority of the NSAIDs we have are going to be non-selective, meaning they affect COX-1 and COX-2 equally, right, to decrease prostaglandin synthesis. So most of them are going to have that risk for causing GI issues like peptic ulcers and whatnot due to inhibiting this prostaglandin synthesis that you see here, right? You've seen these pictures a million times. No point to belabor that. I want to get into the specific ones though, because we kind of talked about the ones for like ENT purposes mostly, but I want to get into more specifics here with some of the other ones. So to give you some examples, aspirin we all know about, but again, I'm not going to focus on that in terms of, I'll talk about why more specifically in a few moments here, but why I don't like this one as an analgesic as often. But certainly we're familiar with ibuprofen and naproxen, used a lot for over-the-counter purposes. But we'll get into other ones like indomethacin, Toradol, or ketorolac, Tolmetin, things like that. There's not any one advantage of one over the other, and a lot of it can be different based on like the dosage forms that are available. So as an example, if you think of IV NSAID, like Toradol is one you go with 9 times out of 10. Doesn't mean there's not IV ibuprofen available. It's just not used as often, right? And again, give them some time to see how it's going to work for them, 2 or 3 weeks or so, before we move on to the next agent. As we know, due to decreased mucus production and that gastric protective barrier, non-selective NSAIDs can be a problem in the long term for patients, so you do want to watch out for that. We do know there's a bleeding risk. This is limited to as long as the drug is in the system, because all of these are reversible inhibitors except for aspirin. Aspirin's the only irreversible inhibitor. It carries a long-term bleeding risk associated with it because once it affects those platelets, the platelets is affected. Low risk for hypersensitivity reactions. And you're going to find that this is not great for late-stage pregnancy. Basically, you can find that NSAIDs are, we'll talk about pregnancy categories later on, but NSAIDs tend to be relatively safe during the first and second trimester. It's in the third trimester, it turns into what we call a category D, which means do not use unless there's some obvious case where the mother could benefit despite the fetal harm. There's not really many cases like that because of the fact that it can delay spontaneous labor. It can also prematurely close the ductus arteriosus in the fetus, which can impair blood flow, especially if the baby's not breathing yet. They haven't been born yet. So we'll get into that a little more later on in OB-GYN. So some other things to consider too are some of the side effects you can see with NSAIDs. So for instance, some people are predisposed to bronchospasm due to NSAID exposure. And you're like, well, why would that happen? Well, if you go back to that picture, I'm not sure if I showed it again. You go back to this picture here, if I inhibit this cyclooxygenase, but I'm in a state where I'm producing a lot of arachidonic acid, you end up shunting this over to the lipoxygenase pathway and produces leukotrienes. If you recall back to when we talked about asthma, leukotrienes are bronchoconstrictive. So some patients are more sensitive to that than others. And if you hear about someone who has an aspirin allergy or an ibuprofen allergy, and they say, "Oh, well, I had an asthma attack," this is what's happening. They're shunting all that arachidonic acid to leukotriene synthesis. So again, not everyone's going to run into that, but it can happen. Again, this can have some hepatic impairment, so you do want to watch for that. It's less likely than certainly acetaminophen, but you can watch for that. And recall, older patients especially, if they have renal impairment or if they're really dependent on prostaglandins keeping that afferent arteriole open in the glomerulus, this can reduce that, right? So you can end up inducing renal dysfunction in these patients. So be cautious, renal disease, older patients, that those are the ones that are more likely to experience that. So let's get into individual agents here while I still have a few minutes to talk. First off, we have acetyl salicylic acid, or aspirin. That's where you get the ASA from. If you're ever curious about where the abbreviation comes from there. We recall this is a non-competitive or irreversible inhibitor of the platelets. That's why we get the good, long-lasting antiplatelet effects from that. But again, it's a non-selective, works for COX-1 and COX-2 pretty equally there. Now, the reason why I get a little hesitant to use aspirin as an analgesic is because that's a relatively narrow therapeutic index here. You can see that, with lower doses, anywhere between 81 milligrams and a gram, you're getting the usual antipyretic, antiplatelet sort of activity here. It's all well and good. But as you start to get up much higher than that, especially if you're taking multiple big doses a day, you can run into what we call salicism, which is basically aspirin toxicity. And there are a few things I get more worried about than a really severe aspirin toxicity. It can be quite fatal if not treated appropriately, which I'm not going to get into today. But just know, be cautious with this. Also, again, in kids, you probably don't want to use this because of Ray's syndrome risk to the post-viral, so I would be very cautious there as well. So again, some limited uses for aspirin. So overall, I just don't use it as an analgesic. Any cardiac protection, go for it. You got Kawasaki's disease, do it. But otherwise, I just don't really like it all that much as an analgesic agent there. Okay. Although, interestingly enough, may also benefit some hypertensive preeclamptic patients, but use is limited there as well. Okay, so we talked about Ray's syndrome before. Just remember that's in the post-viral phase, kids are getting aspirin, usually as an antipyretic, can lead to significant mortality if not caught early. Basically causes this fatty liver encephalopathy, very, very nasty stuff. So that's why typically if the kids are less than 16, I just avoid aspirin unless they have a really compelling indication for it. And again, they're post-viral, a lot of times their symptoms look very similar to what they're experiencing before, which is why it's so difficult to really identify there. So I'm not going to get into the treatment and all of that, but just as an FYI. Okay, now I want to talk about the other NSAIDs. That's what I really wanted to focus on. You're going to find here that one of the big categories is what we call the propionic acid derivatives. I don't really care that you know the different classes of NSAIDs in terms of their chemical structure. Just know if ibuprofen doesn't work for a patient, it doesn't mean something like naproxen is not going to work. It doesn't mean Toradol is not going to work. It's very dependent on the patient, see what they're going to experience. Again, these are good for mild to moderate pain. We'll see that Toradol is going to be a little bit better for more severe pain. We'll talk about that specifically in a minute here. And it's used for all kinds of stuff, muscle pains, arthritis, dysmenorrhea, really anything. Run-of-the-mill pain can be treated with our NSAIDs here. Now, some of these we may be familiar with, so things like ibuprofen, naproxen we've seen before, but some of the newer ones we have not run into include things like ketoprofen, phenoprofen, flurbiprofen, which is kind of fun to say, and then oxyprosin. A lot of times the big differentiators here are going to be the duration of action. So for instance, like Daypro here is 40 to 60 hours. That's going to be good for chronic pain because it's going to cover the patient for that whole 24 hours. If I just have, a more of an acute pain issue, I don't really need that big of a half-life, then something like ibuprofen is reasonable, right? Or if you ever watch the advertising for naproxen, they like that because it's longer half-life. Usually want to take it once to twice a day maybe, whereas like ibuprofen, usually 3 to 4 times a day. So other ones you can run into, maybe we haven't covered before, including things like indomethacin. I think someone mentioned that for use in gout. I was most familiar with this one being used in the NICU, actually. There's an IV form of indomethacin that was available that we would actually use to close the ductus arteriosus. And you're like, wait a second, you just said earlier that NSAIDs can prematurely close the ductus arteriosus, so don't use it in the mobs. But right, sometimes when these kids are born, that ductus arteriosus stays open, and we need to close it for them because it's causing issues in terms of their fetal circulation now that they're born and they're breathing on their own. So sometimes we'll do what we call a chemical ligation, where we will give an NSAID and actually decrease prostaglandin synthesis in order to close that. And if that doesn't work, then sometimes they'll go and do a surgical ligation. So if we can avoid doing surgery, that's always a good thing. Interestingly enough, if you have a kid that's born and their ductus arteriosus is closing too early, we can actually give them prostaglandins. So you can actually give alprostadil in order to keep that open. So just a little side note there. For the most part, the side effect profile is going to be very similar amongst all of these. There's nothing really unique with any of these. So again, hematologic toxicity, there's a risk for bleeding, things like the ulcers in the stomach. It's going to be class wide. So no big differences there. Some of these are more some of the more intense ones like indomethacin are better for short-term use. They tend to be a little bit rougher on the stomach. So that's why they recommend shorter courses here. Toradol, I love Toradol. This is a great drug. This is great if you have a patient who, is having more moderate to severe pain, but not quite needing an opioid. This is a good one because this is a parenteral product, IM or IV, really good for like migraines, good for all kinds of stuff where you don't really want to utilize an opioid. This is a great drug, very opioid sparing. And we use this a lot, like in the post-operative period, to try to reduce the amount of opioids people require. So it uses everywhere, ER, ICU, surgery, everywhere it gets used. However, it's you can only use it for a short period of time because of the GI effects are much more intense with this one. So we basically limit it to usually 3 to 5 days, no more than 5 days, because the risk for GI effects is going to be too high. So this is a good one to utilize there, but again, short courses, right? Ibuprofen you could probably use much longer with no GI issues. This one very limited, but very good at what it does. Tolmetin's another one that is prescription only. It's going to be similar in activity to things like what we saw with like naproxen or oxypros and things like that. So nothing notable there. A little bit worse in terms of side effect profile. So again, I don't see a ton of use of Tolmetin. And piroxicam is another good one. Has a nice long half-life, so this is good for kind of just one-time daily use. So some people like it from that purposes there. What I want to get into now is meloxicam. This one is notable because this actually has more selectivity for COX-2. So the benefit there being is that it helps to limit some of the GI effects. So if you have someone who's going to be on something for chronic pain, meloxicam, and you're worried about their stomach, meloxicam is a good option to use because it has a little bit of selectivity for COX-2, but it kind of spares COX-1 a little bit. We'll talk about why you don't want to do just pure COX-2 activity. That's bad. You don't want to do that. But by having a little bit of a balance here, this is beneficial. Nabumetone also has some degree of COX-2 selectivity. You see this more used for like osteo and rheumatoid arthritis. But again, nothing too notable with this one other than the fact that it's kind of in the same camp as meloxicam due to that COX-2 selectivity, which is good to know. And then diclofenac. This also has some decent COX-2 selectivity. This one you're going to see used more often topically. So that's where you get that Voltaren gel that you can get access to over the counter now. Again, benefit of using topical. It's better for smaller areas of pain, but again, topically working so it doesn't get systemic. So I don't worry about GI ulcers with Voltaren gel because the patient has to basically bathe in it to get enough absorption to be a problem, right? Okay, so I'm going to finish up by talking about COX-2 inhibitors. Basically, you're going to see that the idea of using COX-2 selectivity is to spare COX-1. That way, that can still produce the prostaglandins necessary to protect the stomach, and thus you would have no peptic ulcer issues, and it would just be good anti-inflammatory activity. The problem is that there's also other activity that COX-1 and COX-2 have in terms of things like angiogenesis. So what we found is if you only use a COX-2 inhibitor, pure COX-2 inhibitor, you end up finding that there was a huge increase, not huge, but there was a big enough increased risk in heart attack and stroke that it actually got removed from the market. And this was something that was not recognized until it got put on the market because clinical trials only deal with thousands of people. Once it got started to be given to millions of people, and this was like a really big deal. This is like a huge game changer when it came out because of not having the GI effects. And so this is a blockbuster medication. Millions of people were using it. It was only then that we were able to find the statistically significant change that was happening causing death. So the big one was Vioxx, rofecoxib. There's another one called valdecoxib that also got removed from the market. We have one left that we use most commonly called celecoxib or Celebrex. This one is not purely selective for COX-2. It's more so like if you look at the spectrum and go to something like ibuprofen, have no selectivity. You have meloxicam, has a little bit of selectivity. Celecoxib even further on the spectrum there. But from what we know, it doesn't look like it causes a big risk and increase in heart attack and things like that. So it appears to be safe to use. Okay, so really, rofecoxib, valdecoxib, removed off the market. Don't even worry about those. This is kind of old news when I was in school, like 10 years ago, but it's still a good historical point to mention. Celebrex we still use. A Totolac I see occasionally. I've actually seen more vet use for a Totolac than anything else for like dogs with arthritis and whatnot. But celecoxib is the main one you're going to see in people most often. And if you look at it like in terms of selectivity, it makes sense because celecoxib is much less selective than something like rofecoxib, so that's why we get away with having less cardiovascular effects, nothing serious enough to take it off the market, as compared to something that was more selective. Okay. Again, you can read the balancer. Basically, is an issue of like blood pressure and angiogenesis, and just that disbalance made it such that it was more likely to have less blood flow going to the brain and the heart, and that's where you saw the strokes and myocardial infarctions. Okay, so that's that. I think I'm going to cut it off from today. I don't want to use the next 4 minutes to start something I can't finish. But do you all have any questions? Oh, I got a few questions right here. Someone said, would you consider using Cytotec with Toradol, or would you just be for patients with GI history or risk? I would say not normally. Normally, if you're only going to use it for 5 days, it's not going to be a problem. If I had a patient who was coming in who needed Toradol, but they have a history of like kind of chronic NSAID use, or if they had a history of ulcers or something like that, I'd probably use a PPI first. I think it's going to be a lot more available and probably cheaper than using misoprostol, so I'd probably go with that first. That's my 2 cents. You might find someone else that doesn't do that. Someone said, sorry I fell behind. That's okay. Would the drugs listed before the COX-2 inhibitor slide also fall under the propionic acid derivative? Some of them fall outside of that. Honestly, I should probably take that off the slide. I don't really care that you know the different chemical structure classifications. If you can identify it's an NSAID and know which ones are more selective for COX-2, that's good enough for me, right? So if you can identify sort of the differences between like a celecoxib and meloxicam versus ibuprofen, that's good enough for my purposes. Okay. That makes a sense. That's a lot. Thank you all for joining me. I really appreciate it. I hope you all have a fantastical weekend. Hope it's wonderful. Yep. Hopefully you guys don't have anything after me. You guys can go and have a nice break. But I will see you all next time. I think we meet next Tuesday. Oh, we have a Tuesday, Wednesday, Thursday block. That'll be lots of fun. It'll be great. Cool. All right, guys, have a great day. I will see y'all later.